Last Thursday, I met Annie. Annie lives at home on her own. Like many of us, she has family around, but they're not close. So her daughter lives abroad and her son's about an hour's drive away. And Annie has comorbidities, and the main one is COPD. It was an interesting visit because I had to climb over a tube for oxygen that went into every single room of our house. So you're sort of like a skipping rope stepping over it. But that enables her to be at home. And in the corner, she has a defib, and then she has a number of types of oxygen to enable her to get out and about and meet her friends. Annie's lucky, though, because she does have some friends, so she doesn't have the social isolation that the majority of our patients have in the community. So I went with Julie, who's her nurse, and Julie was talking to Annie about the fact she'd just been diagnosed with terminal CA, and she had about 3 months left to live. I don't like mics because you can see I'm shaking, so bear with me. And Julie wanted to talk to Annie about hospice care and Macmillan nurses. But Annie's chosen not to have any of those things. She wants to enjoy the rest of her life and live at home and die at home. And what she said to Julie was, I don't know why you're asking me, Julie. I don't need anybody else. If I need anything, I pick the phone up and you sort it out. And then she looked at me and said, you her boss? And I said, yes. And she said, well, I need to tell you that I've had Julie looking after me for 2 years. And before she did look after me, my world was a lonelier, darker and painful place. Annie is 95 years old. That's the community. So for me, the community is the 7th C. We allow people to stay at home. We allow them to be well. But how do I know that everybody is a Julie? Well, there's the challenge. So let me see if I get this right. Oh, I've gone one too many. Right. So we have, I cover North West London and South West London. I have 50 sites. So I don't have a hospital. I can't go and get my sandwich and pass 3 wards and have a look at what's going on. Okay? And it can take me 50 minutes to get from one building to another. And then I have to hope that the nurses are actually in the building, they're not out of people's homes. So actually knowing what is going on is really difficult. And most of our clinicians work on their own, they don't have other people. So I'm very much dependent on word of mouth. Now we do get loads of metrics and we get all sorts of balanced scorecards, but actually there's nothing like hearing it for yourself. Then IT in the community, well, you know, quite a lot of the staff are cracking on a bit. They're a bit like me. And to them, a mouse is something that you give cheese to. So we still have some teams where they're sharing one computer between 5 or 6. So again, that remote working, I think there's a little pink pig in the sky talking about that in a lot of our services. So it varies a lot. So there's a real challenge there as well. But the biggest one for me is the politics. Okay, we hear a lot about out of hospital. We hear a lot about what's going on. Actually, when you're in the community, it just feels as if people are coming home earlier, sicker, but without any additional resources or staff. And it can feel very, very challenging. And people don't come out with chronic illnesses. People are really acutely ill. So we have mini ITUs in people's homes so their children can die in their bedroom with their parents and not in an ITU unit itself. And I think there's a misperception about how acute it can be. So for me, the main way I know what's going on is to actually go out and listen and see. Because you can look and not see, and you can listen but not hear. So I try and go out as much as I possibly can. And the staff do tell you, they forget who you are after about 10 minutes, and particularly students. I love students, because students really tell you as it is. But we can sometimes get together. These are some of my wonderful staff. And we had a launch in July for Compassion in Practice. Each table had one of the 6 C's, and we talked about values and behaviours. And I challenged them in the same way I'm going to challenge you today, okay? Because when I have people come to something like this, we're preaching to the converted, aren't we? Quite often people come because they already believe in providing really high quality standards. But how many of you can put your hand on your heart and say that you have seen something that you didn't think was quite to the high standard or wasn't quite right, and didn't do anything about it. I doubt anybody in this room can say that they've never done that. And if I give you a really small example, bare below the elbows in a clinical area. A watch isn't bare below the elbows. So how many times have you seen that and thought, do you know what, they're a bit more senior than me, or it's not that important enough, or that's okay. I would never do that. But hey, you know, it's in the too difficult box. And that's the sort of conversations I had with the community staff, because they sat there and they looked shocked when we read out bits of Mid-Staffs and Francis. But then I said to them, well, actually, I've seen that when I've been out with your teams. I've seen things that aren't quite right. I've heard nurses talking to patients as if they're 3 years old, and you didn't do anything about it. So there's something about the challenge that we really need to challenge ourselves and others about. Now, this is the lovely Linda. I know you looked at me, but actually it's the other lady I want you to look at. And she's one of our patients. And I interviewed her live in front of all those staff, and we've shown it at the board and various other places. And I asked her what it felt like if somebody carried out the 6 Cs and what they meant to her. And then we talked about what it felt like if they didn't do that. And some of my very experienced, cracking on staff were in tears at the end of that discussion. And there's nothing like hearing it from somebody themselves to really strike home. And the thing that I remembered most was that she said that when people behaved with care and compassion, that she wasn't frightened. My goodness, what do our patients feel like if people aren't behaving in that way? It's quite shocking, isn't it? I do have a hospital, for those of you who are acute, but we also provide lots of other things from there, lots of children's services, therapies, walk-in centre. And it's one of the easiest places to start as a pilot, then roll out across the community about a clinically led approach to the 6 Cs. So we've been doing that with our staff. And one of the first things we did was give them the ownership to actually come up with their own pledge. So we have a mission statement, don't we all? And we all have lots of objectives and all the rest of it. And our mission statement is to provide services that we or our families would want to use. Probably the same as some of yours out there, because they're all very similar. But for teams and services, they need to understand what is their own pledge as well and what it is they're aiming for. So these staff have had an opportunity to do that, and that's what they came up with. And I'm not going to read them out. What I am going to tell you is that we have 6 work streams, each led by a different clinician from a different background. And they have set themselves really, really challenging objectives and outcomes for their work streams. So you probably don't get that many pressure ulcers. Let me tell you, we get quite a few. I think we have 40 at the moment. So one of them has set the challenge to themselves about having 0. And that's a real challenge because it's working with social service partners and voluntary sector and everything else, because the majority of them aren't caused by the nursing care. So, you know, that's one of, just as an example of one little objective. And the other thing we've just done is signed up with the Patients Association. And we're going to do a joint piece of work whereby the Patients Association and student nurses from our 2 HEIs come together and actually look at our staff, observe them, and test them out around the 6 Cs. And they're going to give them direct feedback. And then that comes back to me as well. And obviously we look at what we do with that learning. But people talk about KPIs. Well, actually, they're as good as the people who fill them in. And you can skew them a bit to get what you want. And as a risk person, I have that as well. So, but, you know, it's not the same as what you see and feel. And you know, the atmosphere of a ward is much more important, or somebody's home, than actually the KPIs. They give you an indicator, but they're not the real truth. So, lastly, I think, yep, I told you I'd be very quick. These are 6 of my wonderful staff. Aren't they lovely? And I guess what I want to say, I called the community the 7th C because I truly believe it is. You know, we should be able to care for people at home for as long as they want, for as well as they want, if that's what they want. And we shouldn't have to ship them off to other places or not be able to cope with what they've got. But each person deserves a really high standard of care as well. Each person deserves to be looked after as if it was your mother or your father or your brother or your sister. And sometimes it's really hard to do that or to know it's going on. And one of the main ways of doing that is to continually challenge the staff, continually challenge yourselves. You know, I continually challenge myself. I'm always saying to them, if you don't like what I'm saying, tell me, challenge me. They didn't do it for the first year, now they do. It's the only way that we move on and really provide high quality services. Okay, thank you.